Hi folks, this is Alan Heckman from the Physician Assistant Program at DeSales University, and today we're going to be talking about the complete metabolic profile along with some other tests that you might order in conjunction with a CMP. Many elements of the complete metabolic profile you're already familiar with, and that is because much of this test includes the elements of a basic metabolic profile plus a total bilirubin, an AST, an ALT, Elkfoss, and a total protein. So basically you're getting a basic metabolic profile plus these liver function studies. It's important to note for the remainder of this presentation, I'm going to talk about other tests as well, and those are tests that you're going to need to order separately. They do not come part of the complete metabolic profile, and I'll try and point those out to you along the way. We're going to spend some time now talking about the liver function studies. As mentioned on the previous slide, many of these tests are going to be included as a part of the CMP, but some of them you're going to have to order as separate tests. This is very much institutional specific, and so you'll just need to be familiar with wherever you're working what is included in a panel and what is not included. Now with regards to LFTs, they're not all inclusive, but they're going to give you a pretty good idea as to problems associated with the liver. They can detect injury to the hepatocytes, in which you would see an increase in your AST, ALT, and possibly the Elkfoss. They can test the liver's capability of transporting or metabolizing organic anions or even metabolizing drugs. They can look at their biosynthetic capability by understanding albumin and clotting factors, and they can also test for signs of infection or inflammation of the liver as well. The total bilirubin is a test that you will get as part of the complete metabolic profile. Now, if you remember from your GI lectures, bilirubin comes from the breakdown of heme, which results from the hemolysis of red blood cells. This bilirubin is what gives bile its pigmentation, or at least most of its color. Elevated bilirubin levels can be due to, for the most part, three causes that sometimes can occur simultaneously. So when you're seeing an elevated bilirubin, you have to start thinking about, are any one of these three causes involved? And that could be the overproduction of bilirubin, impaired uptake, conjugation, or excretion of bilirubin, and then backwards leakage from either a damaged hepatocytes or some type of bile duct obstruction. Most patients that have elevated bilirubin levels will potentially show a clinical sign of jaundice, meaning that their skin's going to be yellow. In order for this to happen, they need to have a bilirubin greater than 2.5 in an adult to see this jaundice. In the neonate population, though, it needs to be greater than 5. Here's some important things to know about a total bilirubin. It's not a sensitive indicator of hepatic dysfunction, and it's not specific enough to indicate the cause of the problem. Now, with that said, here are a couple tidbits of information, though, that you can use, which will help you when you're interpreting a total bilirubin. And that is, an uncomplicated hemolysis rarely causes a total bilirubin greater than 5. So that's important to know. Patients with parenchymal liver disease and incomplete biliary obstruction due to a stone usually have a lower total bilirubin than if the obstruction was caused by a malignancy. Your total bilirubin will be elevated in renal failure because the kidneys are not able to excrete the bilirubin. And this last point here, a normal total bilirubin essentially rules out any significant impairment of excretion or excessive hemolysis of red cells. So these 4 bullet points here are pretty helpful when you're trying to interpret a total bilirubin. All right, now let's talk about direct and indirect bilirubin. This is separate from the total bilirubin. This would be a separate test that you would need to order. Now, if you recall, unconjugated, otherwise known as indirect bilirubin, is bilirubin that is bound to protein, and direct or conjugated bilirubin is bilirubin that is freely circulating without being bound to a protein. Okay? If you have elevated levels of unconjugated bilirubin, well, that's typically the result of overproduction, such as from hemolytic anemia or the presence or breakdown of a large hematoma, or it could be from impaired uptake or actual conjugation of the bilirubin itself. Now, elevation in conjugated bilirubin or direct bilirubin is more commonly due to a decrease in excretion due to some type of liver disease or some type of backward leaking of conjugated bilirubin, usually from an obstructed source such as a stone or a tumor. This bottom point down here, in a healthy person or those with Gilbert syndrome, the total bilirubin that you're going to find when you order that total bilirubin, most of that is going to be unconjugated. So when you're looking at that number there, you have to think in your head that most of that is coming from unconjugated bilirubin. Okay, and that means it's bound to protein and it's not water soluble. All right, moving on now to the ALT. This is an enzyme that occurs in high concentrations in the liver, but you can find low concentrations of this in areas like heart muscle and kidney. That's heart muscle. I'll put a little T there for you. T. Heart muscle and kidney. The ALT will be increased in moderate to high liver disease. It can also be found in liver cancer as well. You'll have an elevated ALT. Other conditions such as viral hepatitis, alcoholic cirrhosis, and even biliary obstruction. However, it's important to know that the ALT is more sensitive at detecting liver disease than it is at detecting biliary obstruction. All right. In addition, patients with a severe shock could also have an elevated ALT. The ALT, though, will be decreased in cases of malnutrition or severe liver disease. And the reason for that is because the hepatocytes are just too sick in order to cause an increased ALT. One more important fact to note is that patients who have a lot of centralized fat or adipose tissue will have a falsely elevated ALT. They found through studies that there's a correlation between ALT and fat trunk. And some newer data out now is suggesting that we redefine the abnormal values, and they should be more based on the patient's age and their BMI, so that we don't have falsely elevated ALTs, and we're doing further testing on folks where it's probably normal based on their BMI. Instead, we treat it as an elevated ALT, and we end up doing further testing on them that will potentially be unnecessary. The AST is another liver enzyme test which is part of the complete metabolic profile. This is an enzyme that's found in tissues that have high metabolic activity, such as the heart, the liver, the kidneys, and the lungs. However, it's important to note that lower concentrations will be found in organs that don't have such high metabolic activity. So any of the organs listed here, the higher the metabolic activity of the organ, the more AST it will put out. And some other organs, such as maybe the spleen, that don't have as high metabolic activity, you will find a lower level of AST being produced by these organs. Now, what's important to know about this is that this enzyme will be released into the blood after some type of cellular injury or death. And the levels directly correlate with the number of damaged cells and time since the injury. And typically, it takes about 12 hours for the level to rise following some type of cellular injury or death, and they will remain elevated for about 5 days. We typically are going to use this test in the evaluation of liver and heart disease. These are specific areas or conditions in which you're going to see an elevated AST. You can see it following an acute myocardial infarction. And this would be anywhere from 4 to 10 times the normal value, peaks in about 24 hours. It's parallel to the CPK levels, which we're going to cover in a later presentation, and tends to fall back to the norm by about 3 days after the cellular injury or death. It's seen in liver disease here anywhere from 10 to 100 times that of the normal value in patients with acute or chronic hepatitis. Now, an important fact here to know is that the ALT will be greater than the AST in that situation there. So I just kind of want to star that Make that part of your attention there. That's important to know. In addition, drug-induced or alcohol-induced cirrhosis or hepatitis, the AST will be greater than that of the ALT. That, too, is also important to know. You can also have elevations with conditions like infectious mononucleosis and other liver diseases or cancers. Tissue trauma, either from a direct trauma or irradiation of skeletal muscle, malignant hyperthermia, brain trauma, crushed injuries, muscular dystrophy, those areas too, you will see an elevated AST. In addition, hypothyroidism, you will probably see an elevated AST. The areas here that you really are going to need to focus on and where AST is going to be more important to you, in my clinical opinion, is going to be in the area of liver disease. So that's important to understand. GGT is an enzyme that is mainly present in the liver, kidneys, and the pancreas. Its highest source is found in the kidney. However, when we see it on a serum blood test, we assume that the source of that in the serum is coming from the liver. We use this test to determine liver cell dysfunction and alcohol-induced liver disease. That's important to know. Its sensitivity is great at detecting hepatobiliary disease, but its usefulness is limited by its lack of specificity. This is why a GGT should always be ordered and interpreted in conjunction with other liver function tests. Now, it is very sensitive to the amount of alcohol consumed by chronic drinkers. And you're going to use this test to monitor a patient with chronic alcoholism to see if they have been drinking or not. If someone tells you they're a chronic alcoholic and they have been alcohol-free for quite some time, then their GGT should be low. If it's elevated, then it's a pretty good indicator that that patient has been consuming alcohol. Remember that GGT is elevated in all forms of liver disease or liver cancer. So because it would be elevated, it's not specific. It won't tell you what specifically is wrong. It's just going to be elevated in general. So you know that there's a problem somewhere, but it's not going to tell you specifically what it is or what's the underlying etiology of it. This is why it must always be interpreted with other liver function studies. One more tidbit about a GGT. This is not part of the complete metabolic profile, and this is a test that will need to be ordered separately. An Elkfoss is a test that will come standard on a complete metabolic profile. This is an enzyme originating mainly in the bone, liver, and the placenta, although sometimes you will see it in the kidney and the intestines as well. This enzyme functions best at a pH of 9, which is why it's called alkaline, and it is very age and gender dependent. You will always see a high Elkfoss in the pediatric population. Why? Because they have rapid bone turnover as they're growing. So as long as they're continuing to grow, they're going to have high levels of Elkfoss. So keep that in mind when you're interpreting this study. This is considered to be a tumor marker and also a marker of liver and bone disease. Now, with regards to liver disease, you will see a rise in your Elkfoss with biliary tract obstruction, okay? And with this, the rise will be out of proportion when you compare it to the AST or ALT elevations. In addition, you'll see this with liver cancer, liver disease, obstructive jaundice, from like a stone with cholecystitis, which takes us really back to this point here. And you can also see it with infectious mononucleosis. With regards to bone disease, you'll see an increased Elkfoss in Paget's disease, bone cancer, osteomalacia. However, you will not see an increased Elkfoss in patients with osteoporosis. Other causes here, you'll see it in hyperparathyroidism because of the rapid bone turnover. You're going to see it in lung and pancreatic cancer, CHF, chronic kidney disease, and ulcerative colitis. An important clinical tip here. If you're trying to determine if an elevated Elkfoss is coming from bone or liver, check a GGT, because a GGT will be elevated with liver disease, but will be normal with bone disease. So here's a great opportunity for you to take the liver enzymes and try and figure out exactly if this is coming from the liver or another source. Get that GGT. That's going to tell you it's coming from the liver. All right, so now let's talk about this from the workup perspective of abnormal LFTs. So you have a patient in which you're following up on labs that were done. Let's just say routine labs were done in the office, and they've got elevated liver enzymes. Well, what's your first step here? Well, first of all, you want to take a great history and get a pretty good physical exam. And then based on the history and the physical, you want to take that information and compare it to the liver enzyme studies and see if there's a pattern that exists here that might suggest the etiology of the abnormal enzymes. If you cannot find a pattern to exist there, or some type of information that's going to key you in as to what could be wrong, then perhaps what you might need to do is just repeat these studies in about 2 to 3 months, especially if the patient's not having any symptoms. But ideally, you want to try and find and see if there's a pattern that exists. So look down here at the bottom of the slide. If you have, now this is taking into consideration that all the liver enzymes here are elevated. Okay, so across the board, all the liver enzymes are elevated. Now with that elevation, you're looking for a pattern. And if you have a disproportionate elevation in your ALT and AST, when you compare it to your Elkfoss, that suggests a hepatic cause, meaning your ALT and your AST are really high and your ALP is only maybe moderately high, okay? That's indicative of a hepatic cause. A disproportionate elevation in the serum Elkfoss when compared to the AST and ALT suggests a biliary cause. So once again, your AST and your ALT are moderately elevated, but your Elkfoss is through the roof. That would suggest a biliary cause. Now, in both cases here, a serum bilirubin can be elevated, and so it's not really helpful in differentiating between the two. So ideally what you're looking for are these two patterns here, and I left you a little love note here that says you need to know these. That's very important. A couple of other things to consider here when you're working up abnormal LFTs. A low serum albumin suggests a chronic process rather than an acute process. So when you're seeing a low albumin, you should be thinking things like cirrhosis or cancer, a chronic process. A normal albumin level suggests more of an acute process. So when you're comparing it to your other liver enzymes, if you have elevated ALT, AST, but you have a low serum albumin, then you should think a chronic process is going on here. If you have elevated liver enzymes and you look and your albumin is normal, then you should think this is more of an acute process. Now with regards to chronic syndromes here, chronic elevations in LFTs is defined as 6 months or more. That shouldn't be of more. That should be 6 months or more. So if you had elevated LFTs for 6 months, now at that point it's considered to be chronic. In addition, mild elevation is defined as less than 5 times the upper limit of normal. So depending on what your specific lab has defined as the normal range for those liver enzymes based on your laboratory, you can have up to 5 times that amount of the upper limit of normal before you're going to consider this to be anything significant in terms of elevation. Let me give you an example here. Let's just say hypothetically your lab says the upper limit of normal on an ALT is, 40. So therefore, you'd have to have it above 5 times that upper limit, greater than 200, in order for you to say, wow, that's a pretty significant increase in your LFTs. So if you came back with an LFT, or an ALT of like 100, 110, that would consider to be maybe mildly elevated, but not like a one that you would really be sitting there worrying about immensely. Okay, so keep that in mind too. It needs to be greater than 5 times the upper limit of normal for you to call that a true significant elevation. All right, so now you got a patient that you're seeing in your office that you've been following for quite a while who is not having any significant complaints. But when you do your routine blood work on them, they chronically have elevated LFTs. So now we need to dig into this a little bit further. So how do we do that? Well, you start with step one here. First, take a look at their medications and see if there's any meds that this patient's on that could cause elevated liver enzymes. Things such like Tylenol, antibiotics, statins would be another big one, or any of the anticonvulsive medications. So take a look at that and see if that could be a cause. If that's not causing it, then go down and ask your patient, do they drink a lot of alcohol? Now, a key here that will help you decide if this patient is using alcohol or not, or something that should make you think that, is you're going to look for a 2-to-1 ratio here. A 2-to-1 of your AST to ALT. And you're looking to see if it's a greater than 2-to-1 ratio. If your AST is 2 times greater than that of your ALT, that is a lot of times indicative of someone who's using alcohol. All right? In addition, you could get a GGT. And if that GGT is elevated, as we mentioned earlier, that also is going to help point towards alcohol. So once again, if you're seeing an AST that's 2 times greater than your ALT, and you accompany that with an elevated GGT, then alcohol could be the cause of your elevated liver enzymes. You need to know that. That's real important, okay? Okay, so now we're on to step 3. You've basically at this point have ruled out any type of medication that's been causing this, and you've ruled out alcohol as a cause of these chronically elevated LFTs. So now you should be asking yourself, could this be a hepatitis process? Now, a patient with hepatitis A is going to have an acute viral illness, so they're going to be sick, and they're going to be presenting to you with sick symptoms. But let's just say this patient here is not having any major complaints, but he's got these chronically elevated LFTs. Well, you could see this in patients with a chronic hepatitis syndrome, such as hepatitis B or hepatitis C. So in this instance, you're going to want to order hepatitis testing on them. Now, to test for hepatitis B, and we're going to talk more about this coming up, you're going to start with a surface antigen, a surface antibody, and you're going to order a hepatitis B core antibody. All right? For hepatitis C, the initial test you're going to order would be a Hep C antibody profile. Now, if that does not yield anything, then you should ask yourself in step 4 here now, is there any reason that this patient would have a hemochromatosis? And if you're suspecting that, then what you want to do is you want to order an iron and a total iron binding capacity. And then you're going to calculate a transferrin saturation. If that saturation is greater than 45, you're going to order a serum ferritin. Now, you only will order the serum ferritin if the transferrin saturation is greater than 45. Why? Because ferritin is an acute phase reactant, and so that can be elevated in all kinds of situations. Even up here in hepatitis, you could have an elevated ferritin level. So it's not going to be an accurate test for you. So you have to get the elevated transferrin saturation. That's got to be greater than 45. If that's the case, and you get a ferritin, and your ferritin is greater than 300 in a female or greater than 400 in a male, with the transferrin saturation of greater than 45, then you have enough to make the diagnosis of hemochromatosis. So let me go back and review that. If you're thinking the patient is hemochromatosis, you're going to order an iron and a TIBC, and you're going to calculate the transferrin saturation. If that's greater than 45, then you order the serum ferritin. If the serum ferritin is greater than 300 in a female or greater than 400 in a male, then you've met the diagnostic criteria for hemochromatosis. All right, now we're on to step 5. We've ruled out medications, alcohol, hepatitis, and hemochromatosis. So now we just got to ask ourselves, gee, does this person just have fatty liver disease? And is it just plain old fatty liver disease, or is it this NASH, this non-alcoholic steatohepatitis? And if you look at the PowerPoint that I posted for you, you'll see on the instructor notes at the bottom there, I gave you a little bit of background. Now, you should have already had this with your GI lectures, but this should just be a little bit of a review for you. So remember that NASH resembles alcoholic liver disease, but tends to occur in people who don't drink or just drink very little. The major feature is that you have fat in the liver along with inflammatory changes and damage. That's the important factor there. Most people with NASH tend to feel well. However, NASH can be severe and can lead to cirrhosis. It only affects about 2 to 5% of the population. Now, in 10 to 20% of the population, they have fatty liver disease, but no inflammatory changes or damage that you can see. They just have what's called a fatty liver. It's not normal, but you're not going to have the destruction like you could have with NASH. All right, so keep those things in mind. Now, these patients here, they typically present mainly with just mild elevations of LFTs, which is kind of the scenario I've been giving you here. This patient's been coming to see in the office with chronically elevated LFTs, doesn't really have any symptoms. It's more common in women and is definitely associated with obesity, type 2 diabetes, and high triglycerides. Your AST and your ALT ratio, not ration, your ratio is usually less than 1, and the workup typically includes an ultrasound. That's what you're going to start off with. Most fatty liver disease can be picked up with an ultrasound. However, what the ultrasound will not be able to tell you is that if this is just plain old fatty liver disease or if this is this NASH complex going on there. The only way you're going to be able to differentiate between the two is with a liver biopsy. All right? Now, if your ultrasound is not helpful at all, then you might need to go on to something a little bit more invasive, such as a CAT scan or an MRI to help figure out if this patient has fatty liver disease or not. Okay, so if steps 1 through 5 did not yield a cause for these chronically elevated LFTs, then we need to start thinking outside the box and say, geez, is this coming from an organ other than the liver? If you recall, the ALT and the AST and the Elkfoss can be produced by other organs in the body. So now we should start thinking about other systems here. For instance, muscles. Folks can be born with an abnormality with muscle metabolism, or they can acquire a muscle disorder such as polymyositis. Patients with seizure disorders will affect the muscle system, and folks who exercise on a regular basis can also have some abnormalities there. Now, you're not just going to make these diagnoses based on these chronically elevated LFTs. You're going to have some other tests to help you here, such as a CPK, which we're going to talk about next week, and a lactate. In addition, other disorders to consider would be thyroid disease, celiac disease, and adrenal insufficiency. Now, who out of this population can you observe, and who do you need to do a more aggressive workup with? Well, if your ALT and your AST are less than a 2 times elevated or a 2-fold increase, and they have no evidence of chronic liver disease whatsoever, and they're asymptomatic, then those folks you probably could just observe and maybe repeat labs in 6 months, or maybe send them for an ultrasound at some point to assess the liver if you haven't done so already. If it's elevated more than that, then you're probably going to need to dig a little bit deeper and do a little bit more of an invasive workup. Alpha antitrypsin should be familiar to you, as this was probably covered during your respiratory lectures in clinical medicine. Now, this is not a test that you will get as part of the complete metabolic profile. This is a separate test that you would need to order. Alpha antitrypsin is a protein produced by the liver which inhibits the protease release into the body fluids from dying cells. All right, so an AAT is a protease inhibitor that inhibits things like trypsin, collagenase, plasmin, and thrombin during inflammatory responses. Now, when will this thing be elevated? Well, it's an acute reactant, so this is going to be elevated in times of tissue necrosis, inflammation, infection, infarction. All right, so it's not going to be very helpful to you in those situations. Where it might be more helpful to you is when it's decreased, and you're going to see that in conditions like malnutrition, chronic liver disease, or cancer. Now take that even one step further. If you've been diagnosed as having an AAT, an alpha antitrypsin deficiency, this is associated with pulmonary emphysema at an early age. All right, so this is where you're going to potentially see emphysema in a patient who has no smoking history. And this is typically going to be genetically related, and we call this inherited autosomal recessive trait, otherwise known as familial COPD. That is the important takeaway point from this test, all right, is that you're going to have it elevated in all kinds of inflammatory conditions. As it's an acute phase reactant, it's not going to be helpful to you there. But if it's decreased, you should consider malnutrition, chronic liver disease, or cancer. And if you've been diagnosed with an alpha antitrypsin deficiency, this has been linked to people who have developed COPD at an early age. We're going to spend some time now talking about hepatitis panels. We're going to start with hepatitis A. Remember, this is an acute infection that does not progress to a chronic phase, and it's transmitted via the fecal-oral route. The test that you're going to order to see if someone is acutely infected with hepatitis A is going to be an IgM anti-hepatitis A virus study. Okay? In addition, if you've had the vaccination, you could order a total anti-hepatitis A virus, and that would give you an indication if this patient has immunity from a vaccine versus someone who's acutely infected with the disease. This is a diagram that's specific to the hepatitis B virus, and this will make a little bit more sense after we've reviewed it over the next couple of slides here. But you can see on the outside here, this is the surface antigen around the outside here. On the inside is the core antigen. All right. Now you can also have what's known as the hepatitis B envelope antigen, and we'll talk more about that in a little bit. But this picture might help make things a little bit clearer for you as we talk about these antigens. So feel free to come back and refer to it after we've gone through the next couple of slides. Hepatitis B testing can be rather confusing, and so hopefully this is just a review for some of you, but we're going to break down the nomenclature here of these tests, and then we'll kind of show you after a few slides what they mean in terms of representing an acute infection versus chronic versus someone who has immunity through like a vaccination. All right, so the first bullet point here is the hepatitis B surface antigen. And this is just a marker of infectivity, and it indicates the presence of either an acute or a chronic hepatitis B infection. Now, the antibody to hepatitis B surface antigen, formerly known as the Hep B surface antibody, its presence indicates an immune response to a Hep B infection, an immune response to vaccination, or the presence of a passively acquired antibody. So the moral of the story with this one here is that when you see this, and this is positive, it means that there has been an immune response. Okay? The last point here is the antibody to hepatitis B core. This is a non-specific marker of either acute or chronic Hep B infection, but the important point here is that it is not a marker of vaccine-induced immunity. So if they have the core antigen, it means they've had the hepatitis B infection. They don't have this. They don't have immunity or evidence that it was from the vaccine. It's that they've actually had the virus itself. With regards to the core antigen, there is the IgM antibody, all right, to the core. And having this test be positive indicates that there has been a recent infection of hepatitis B, generally within the last 6 months. So if you're looking at the core and there's a positive IgM with the core, it tells you the infection has been recent. All right. Moving on here now to the hepatitis B envelope antigen. This is a marker of infectivity, meaning that people who have this have a high association with rapid replication of the virus, and so getting blood from this patient into your system would significantly increase your chances of getting hepatitis B. These folks are rapidly replicating this virus and are highly infective. Now, in contrast to that, folks down here with the antibody to hepatitis B envelope antigen, they can either present in an infected or in an immune person. But generally, those with a chronic Hep B infection, its presence suggests a low viral titer and a low degree of infectivity. They've had an immune response. They've developed antibodies now at this point. So while they're still they're able to infect others, there's a lower chance associated with it than if they just had the Hep B envelope antigen. This should just be review for you, but how is hepatitis B transmitted? We know that it's transmitted through sexual contact or through blood or other bodily fluids, which is why you treat any bodily fluids from a patient as potentially infectious. Remember, too, that Hep B has a central core containing the core antigen and a surrounding envelope that contains the surface antigen. All right, now let's get down to what these tests actually mean. If you have somebody who has an acute hepatitis B infection, what would the labs look like if you're doing a Hep B profile? You're going to see a positive IgM antibody to the core. As I mentioned earlier, that's going to be telling you that you've had a recent infection, all right? And you're also going to have the core antibody as well. All right. In addition, you're going to have a positive Hep B surface antigen, which is the earliest indicator of infection. And then in addition, you're going to have a positive envelope antigen, which, as I stated just before, has a high degree of infectivity associated with it. There's rapid replication of the virus taking place at this point. So these are all the things you're going to see with an acute Hep B infection. Okay, now folks who are chronically infected but still have the ability to spread the virus to others, so this is different than the acute infection, they're going to have a positive surface antigen, they're going to have a positive antibody to the core, they'll have a negative IgM to the core, because remember that shows recent infection, and this is chronic, and they will have a negative antibody or surface antibodies, meaning they haven't had a true huge immune response yet at this point, which is why they're able to, A, while they're chronically infected, and B, while they're still able to spread this disease to others. Folks who have had immunity due to having a natural infection, they will have a negative surface antigen. They'll have a positive antibody to the surface antigen, so a positive surface antibody. They're going to have a positive antibody to the core. And if the folks have this type of testing, a positive antibody to the core, a positive antibody to the surface, and a negative surface antigen, they do not need vaccination at that point. They have natural immunity to the disease. Folks who have immunity due to the vaccination will also have a negative surface antigen. They'll have a positive antibody to the surface antigen, but they will have a negative core, a negative antibody to the core. All right? In those folks as well, the vaccination is not needed. So the major difference here between folks who have had natural immunity versus immunity through vaccination is going to be this antibody here to the core. All right? So it's going to be positive in folks who have had a natural infection, and it's going to be negative in those who have had who had vaccination against Hep B. Hepatitis C, we know, is transmitted through blood contact, and the test for an acute infection is going to be the antibody to the hepatitis C virus. Seroconversion can take up to 6 months. So initially, if you have a patient that you're suspecting this, you're going to get some baseline labs. But understand it's going to take several months for results to possibly show up. So you're going to have to repeat these labs in the future. Folks who are infected you're going to follow them with what's called a viral load, and you're going to get a Hep C virus RNA, and that will give you a viral load, which gives you an idea of the amount of infectivity those patients have. Patients with hepatitis D, this can only occur with folks having active hepatitis B. So remember, this is a co-infection of Hep B and Hep D. Transmission here is through sex, blood, and bodily fluids. The test that you're going to get for an acute infection, you'll see a hepatitis D antigen early in the disease, and later in the infection, they'll have an immune response, so they'll have an antibody to the hepatitis D virus. And that's how you differentiate between early versus late infection in these folks. Hepatitis E is transmitted through the fecal-oral route and is very rare here in the United States. But if you suspected it, an acute infection would give you a positive IgM to the antibody for the hepatitis E virus. All right, we're moving on here now. This is albumin. This is not part of the complete metabolic profile, so this is a test that you would need to order separately. Its primary function is to maintain osmotic pressure in the vascular and extravascular space. It is a source of nutrition and part of the complex buffer system. Now, an interesting point here is that this is a negative acute phase reactant. And I know that a lot of the labs that we've discussed so far are acute phase reactants, meaning that they'll be elevated when there's stress on the body. However, albumin will actually decrease when there's stress on the body. Another good point here is that hypoalbuminuria has been known to be an independent risk factor for increased mortality in that of older adults. In addition, getting a serum albumin when folks are admitted helps to predict their outcome in the geriatric population. So what do you need to know about this test? It's a non-specific marker, and that the only time it's going to be increased is when there's dehydration. And I'm not too concerned about getting an albumin on somebody to know if they're dehydrated or not. You should be looking for clinical signs or other laboratory tests that can tell you that it would already be part of the complete metabolic profile or the basic metabolic profile. So I would not order an albumin if you're worried about dehydration in your patient. However, a decreased albumin will be seen in inflammation and infection, like I mentioned before. But conditions where you're going to want to necessarily check this albumin would be if you suspected something like nephrotic syndrome, malnutrition, or even heart failure, you could consider getting an albumin. In addition, cirrhosis or liver disease would be a good indicator too to know the status of the liver with an albumin. So those would be indications to order this test, but I would not order it to check for dehydration. Now, as I mentioned on the previous slide, albumin can be a marker of nutrition in your patient. However, we've learned that this test here, a prealbumin, is actually a much better marker at looking at the current nutritional status of your patient rather than albumin. Well, why is that? Well, albumin has a longer half-life, about 21 days, and so it takes longer to reflect the nutritional status of the patient. You're only able to get kind of an idea of how things have been over a longer period of time. However, if you want to know how the patient's been doing nutritionally within the past several days or the past week, then this prealbumin, which only has a half-life of about 2 days, so it responds faster, gives you a much better picture on the nutritional status of your patient. So if you're concerned about malnutrition recently in your patient, then the prealbumin is going to be your test of choice. Amylase is an enzyme that converts starch to sugar. There are two main sources of this in your body, and that would be the salivary glands and the pancreas. Now, an interesting concept here is that salivary amylase is already starting to break down sugars as soon as it enters your mouth. This is why somebody who's like a diabetic, if you needed to give them candy or simple sugar that they could put in their mouth, this is why it's absorbed quickly, because the salivary amylase is there, so the digestive process and the absorption of sugar can already start to take place. Now, the tests that we have for amylase are unable to differentiate where the amylase is coming from. So if you had an elevated amylase level, It's not telling you if the source is coming from the salivary glands or it's coming from the pancreas. You just know that you have an elevated amylase, and so you're going to have to kind of search for the cause. Now, common reasons that you could have an elevated amylase. One of the more common reasons here was going to be a pancreatic cause, and this is going to be due to acute pancreatitis, which can give you very, very high levels. However, understand that many patients with acute pancreatitis can have normal amylase levels. You can also see this with acute exacerbations of chronic pancreatitis and any type of injury, trauma, or cancer to the pancreas, or recent procedures such as an ERCP. In salivary disease, you can see it with infection or a ductal obstruction. You can also see elevated amylase with things like acute cholecystitis, and we all know that that would be related back to pancreatic issues. You can see it with strangulated, infarcted, or perforated bowel, and you can also see it with an appendicitis or in celiac disease. GYN causes of increased amylase could be from a ruptured ectopic pregnancy, pelvic inflammatory disease, or even an ovarian cyst. Other reasons could be in renal disease, and this is because amylase is excreted by the kidneys. So if the kidneys are unable to filter it out, then obviously your serum levels would be higher. Ruptured aortic aneurysm and various medications can also cause the level to be higher. You'll see decreased amylase in things like pancreatic insufficiency, hepatitis, advanced cystic fibrosis, folks who have had their pancreas removed, or folks with thyrotoxicosis. Now, as I mentioned on the previous slide, an elevated amylase can be related to a bunch of different conditions, as you see here. But remember, it's nonspecific, so you're going to have to search deeper when you see an elevated amylase to try and figure out the etiology of it. Lipase is similar to amylase in that it is an enzyme, and it can be found in various areas of the human body. All of them are inhibited by bile acids or salts. All right. Now, pancreatic lipase is responsible for the breakdown of fats to glycerol and free fatty acids. In order to do that, it relies on this here called a colipase. And colipase allows the lipase to attach to a triglyceride droplet, and it prevents the bile salts from deactivating the lipase. You will see an increased lipase in acute pancreatitis, regardless of the cause. Elevation occurs about 24 to 36 hours after the onset of pain, and it can remain elevated for 2 weeks. So this is going to be a better test or a more sensitive test for looking for things like pancreatitis, because remember, amylase may not be elevated in pancreatitis, but lipase is going to be a more sensitive test. In addition, this will be elevated with chronic pancreatitis, pancreatic tumors or stones, renal failure for the same reason that it would be elevated with amylase, cholecystitis, same reasons there, biliary cirrhosis, bowel obstruction, or other medications that would be causing elevated levels. All right, so you've done some labs on a patient, and you found that they have an elevated amylase and a lipase. So now what do? Well, go back to your history and your physical examination here and see if you can isolate maybe the reason why these are elevated. And if the history and the exam are not helpful, then perhaps what you should do is just repeat the test. We've learned that amylase and lipase levels fluctuate throughout the human body at various times. And so perhaps you don't have a cause. Maybe they have no abdominal pain or they don't really have a lot of significant complaints, but they have this elevated test. So you have to look at the clinical picture here and say, okay, maybe I should just repeat the test, and that might be helpful for you, and it may come back normal. Who knows? In folks with acute pancreatitis, you will potentially have an elevated amylase and a lipase early in the disease. But remember that lipase has a longer half-life than amylase, and so the amylase may return to normal. Now, why is that? Well, because amylase is excreted by the kidney without any reabsorption, but some lipase is reabsorbed through the kidney, which is why it has a longer half-life. So as I stated in the previous slide, you don't need both tests to be elevated for you to have clinical suspicion that there's a problem. Just remember that one test is generally going to be elevated longer than the other one. So your patient has got severe epigastric pain that radiates to the back. He's a chronic alcoholic, and you say to yourself, this looks like pancreatitis. But you get the amylase and the lipase back, and they're only mildly elevated. Well, don't get discouraged. Just remember that amylase and lipase levels don't always have to be elevated to have pancreatitis. So keep that in mind. As stated before, remember that lipase is more specific for pancreatitis versus amylase. And interestingly here, if the lipase is elevated to 3 times that of the upper limit of normal, the specificity for this coming from the pancreas is 98%. So it's a really good test to use there. If the lipase is normal and the amylase is elevated, then you should consider sources where amylase just comes from, or other conditions in which amylase only could be elevated, such as peptic ulcer disease, inflammation of the salivary glands, bowel obstruction, or some type of inflammatory bowel disease. Thanks for hanging in there. We've got 2 more tests to go. This is ammonia. This is not part of the complete metabolic profile and would need to be ordered separately. In addition, the 2 previous slides that we looked at, amylase and lipase, they too would need to be ordered separately. They are not part of the complete metabolic profile. All right, so ammonia is the end product of protein metabolism, and this is formed by bacteria in your intestinal tract acting on the proteins that are there. The liver then clears ammonia through the portal system, and it converts the ammonia to urea. So the liver converts ammonia to urea, and then it sends it out through the portal system where it's cleared then by the kidneys. Accumulation of ammonia in the body affects the acid-base balance and brain function, commonly seen in folks with hepatic encephalopathy. When do you want to order this test? If you have unexplained lethargy, vomiting, or any type of evidence of encephalitis that doesn't appear to be infectious in etiology, we can use this test to evaluate for folks with hepatic encephalopathy. But remember that the elevation does not necessarily reflect the degree of encephalopathy. There are some people who have extremely high ammonia levels and only have maybe a slight altered mentation. And there can be patients who have a relatively low ammonia level who are completely unresponsive. So keep that in mind. Now, to reduce these levels, and this would be in folks who have chronic liver issues, where their potential for ammonia is going to be high, you want to lower their protein intake so that they don't have production of ammonia. You also want to consider having them take antibiotics to reduce the bacteria, the intestinal flora, so that they can't produce ammonia as well. In folks who are presenting with an acute encephalopathic event that you believe is be related to hepatic encephalopathy, then the drug of choice here is going to be lactulose. And that works by drawing ammonia from the blood into the colon, where then it is removed through the GI tract. So that is going to be your drug of choice in folks who present with hepatic encephalopathy. Uric acid is the end product of purine metabolism. You're going to find purines in things like red wine, certain types of legumes, and red meat. Now, to break purine down, it needs an enzyme here called uricase. And if you don't have that, you're going to get an accumulation of uric acid that builds up in the body tissues. 2/3 of uric acid is excreted by the kidneys, 1/3 by stool. When are you going to have high levels of uric acid? You're going to have it when there's excessive breakdown of nucleonic acids, and that would typically result in gout. You're going to have it when there's excessive production or destruction of cells. So production would be things like leukemia, but destruction you could see in things like chemo and radiation therapy or tumor lysis syndrome. In addition, you will have accumulated levels of uric acid when you have renal failure, because you have an inability to excrete the levels of uric acid. Now, you may hear out in clinical practice that folks who present with an acute flare of gout, some people will want to order a uric acid level. However, this is not a very accurate test and should not be used to diagnose gout. Many patients that you're going to see with gout will actually have normal levels of uric acid. So, but then again, you can see some patients with high levels of uric acid. It's nonspecific and it doesn't help you make the diagnosis or help you in the treatment process. So, most people will not order this test when they're treating the acute gout flare. Now, a rheumatologist may be treating somebody for chronic gout episodes, and they may order that test in the office to see if that could be the underlying cause, in which case there's medications like uric that someone could take to keep the levels lower. But for your purposes here, if you suspect an acute flare of gout in your patient, it's not a helpful test to get a uric acid. In fact, if you have a hospitalized patient who has a high level of uric acid, it's probably because they're in renal failure and not necessarily related to gout. Renal failure is going to be the most common reason for an elevated serum uric acid level in a hospitalized patient. All right, everybody, thanks for watching. I hope you were able to pick up some tips on these lab tests that you're going to find as a part of the complete metabolic profile and some of the ancillary tests that you might order in conjunction with the CMP. As always, I am available to answer questions. You can email me or come see me personally, and I'm happy to have the discussion with you. Thanks for tuning in, and have a great day.